And we're back. We have Steph Mundt, and this is your first time on, Steph. Thanks for coming on. For people who aren't familiar with you and don't know much about you, can you give us a little intro and background on yourself?
Yeah, so I'm a physical therapist and coach. I coach primarily runners, but do some strength coaching as well. And I'm located in Tempe, Arizona. My business is called Volante PT and Performance. And I graduated from physical therapy school in 2017. I started my business in 2020. And since then, it's kind of morphed into specializing in athletes with bone stress injuries and a history of disordered eating or eating disorder, which, as we'll talk about today, often go hand in hand. So right now I offer both in-person services as well as virtual rehab and virtual performance coaching.
How'd you come up with the name Volante?
Had a lot of indecision around that. Early on, I followed a lot of Chris Johnson's work and Joel Satgast, and took some of their coaching courses as well. And I liked that they had kind of unique business names. Zarin and Trexo are theirs. So I was trying to find something unique, and Volante has multiple definitions, but the one that I resonated with most is flying, or the capability of flying. And I think that really, I guess, again, resonates, or that's how I feel when I'm running fast and running freely. And I think a lot of people can identify with that when they're injury free, they're in the zone, and they're doing what they love.
Yeah, speaking of Chris, the last episode we had on bone stress injuries, and maybe our only one, was with Chris Johnson and Nathan Carlson. And it was also a little bit more general of a topic or conversation, because we also talked about lower limb tendinopathy. So today is only going to be BSI related and all that comes with. And the big thing is differentiating between these low and high risk bone stress injury sites. So let's just dive right into it. Can we start with low risk BSI sites? What does a low risk site mean? And you can kind of take it from there.
Yeah, so low risk is a site that's less likely to progress to a complete fracture, essentially. So lower risk sites, examples would be the fibula, posterior medial tibia, femoral shaft, metatarsal shafts. Those, when they're injured, if you keep running on them, you shouldn't, but if you do, it's less likely to progress to a point where you're going to need surgery, or it's going to have long-term effects, which is different from those high-risk sites where if you continue running on them or they're not caught in time, there's a higher risk for them to progress to needing surgical intervention and having a long-term impact on your activity level. Low-risk sites also tend to have lower complication rates and heal in a more timely manner than high-risk sites.
And I know you'd mentioned you wanted to dive into the difference between these cortical and trabecular sites. Do you want to kind of touch on that now?
Yeah, so when we get into these return to sport timelines, we have really three things to look at. We want to know the site of injury. That's going to give us a range of time. And then we need to know if that site is cortical or trabecular rich. So, bone is made up of a couple different types. And so there's more to it, but if we break it down into cortical rich versus trabecular rich, if we go back to the early days of learning about bone, trabecular is more of the soft, spongy bone that's found more at the ends, whereas cortical is found more in the long bones or the long parts of the bone. So examples of cortical would be femoral shaft, tibial shaft, metatarsal shaft, whereas examples of trabecular would be more proximal or closer to the end of the bone, like femoral neck, the pelvis. So common BSI sites there would be the sacrum or the pubic ramus. And then the calcaneus is actually more trabecular bone as well. So trabecular sites tend to take longer to heal. So we've got, our site of injury, that's going to have its own range. If it's a trabecular site, that's going to make it a longer return to sport, and then the grade of injury as well, which there's a ton of classification systems for bone stress injuries, not completely standardized, but to keep it simple, a commonly used one is the Fredrickson classification, specifically for the tibia, but most of them, or all of them, I think, grade 1 is the lowest grade, and then it goes up to grade 4. There may be some with end at grade 3 or end at grade 5, but the higher number is going to be a more severe injury. So that's going to lengthen out your timeline for return to sport as well. So we'll come back to summarize this at the end, but just to kind of set the stage, when we're looking at these return to sport times, we're going to be dependent on the site, and we know, again, trabecular are going to take longer than cortical sites, the grade of injury, and then there's a few other factors we'll get into that also play into that.
The low risk sites, if you've identified that there is a low risk BSI and you're educating a patient on what are the next steps and what are the management strategies and timelines, what is your spiel and what things are you discussing with them?
Yeah, so within that low risk category, coming back to cortical versus trabecular, trabecular tends to take longer as it's associated with low BMD or low bone mineral, hormonal dysfunction, and restrictive or disordered eating. So those are important to address in all bone stress injuries. At a baseline level, bone stress injuries occur because the demand exceeds the capacity. And if the bone is unhealthy, because the bone mineral density is one way we measure bone health, not the entire picture of bone health. But if the bone is unhealthy, then its capacity is lower. So if you've got even if it's a low risk site, if it's a trabecular site of injury, you want to really come back to these foundations more than you would potentially, or dig a little deeper than you would if it was a cortical site of injury. Does that make sense? So like trabecular, we're going to be like, okay, there may be some biomechanical things here. For low risk, they're going to look at calcaneus, sacrum, and pubic ramus. There may be some biomechanical, there may be some training load things, but these are sites that are associated, again, with bone mineral density issues, potentially restrictive eating, and potentially like the triad is historically what we would think of it as. So those are big rocks for patient education, not just in low risk sites, but really the trabecular classification of these low risk sites. The other thing with really all of these injuries, I think, is the amount of time that it takes to get back. So I think with being a high school runner, shin splints were contagious, in high school cross country. And whether it was actually a tibial BSI or shin splints, no one was really looking into that. But I think the seriousness of these injuries is undervalued. And even though these low risk sites, if they're low grade, people can get back really quick, the recurrence rate is super high. So I think we're not optimally rehabbing or taking enough time to gradually work people back into sport, especially at these low risk sites, because we just think like, oh, fine, they feel better after 2 weeks, put them right back into sport. So circling back, the big rocks for patient education are going to be the foundations for sure. More emphasis on those foundations of eating enough, sleeping enough, how's your bone density, how's your blood work, because you do have enough vitamin D. Those are going to be bigger emphases for the trabecular low risk sites, whereas we'll get into more training load under the cortical sites, and then altogether the seriousness, and that this is probably going to be a slower return than they expect.
And when it comes to low risk sites, as a clinician, or if the athlete or the parent are asking you, do I need to receive imaging to confirm this, or does this need to be pushed out to like an orthopedic provider as well? What are your thoughts there? What would warrant imaging? What would not warrant it? Where do we make that decision?
Yeah, if you suspect a bone stress injury of any grade or any site, definitely refer out for imaging. That can give you a sense of, one, is there a bone stress injury? If there's not, then you don't have to hold them back as much, because these are injuries that do take people out of sport. So if there's not, great, move forward with less conservative treatment. If there is, then you have a better sense of the grade, and then you can prognose a little bit better. So just because it's a low risk site, it could still be a high grade and serious injury. So I think that's another thing that might be contributing to our returning people back to sport too soon in these areas. We're like, oh, it's a low risk site, whatever. Like if they run on it, it's okay. But it could still be a fracture. So definitely refer for imaging. That can give you a better scale of how long this is going to take for them to return to sport, because there's been a few recent studies showing that the grade does correlate with how long return to sport does take. So there is value in that MRI grading.
Are you able to give averages, or is it so site specific that it's hard to say? But depending on the grade, do you have general kind of ideas in your head? Obviously, a lot of this is criterion and objective and multiple other dependent related factors. But do you have general timelines in your head of like, okay, this is way too soon. on average, these are the general timelines?
Yeah, so the most recent systematic review didn't specify by grade, but it gave a range. So we can kind of estimate based on those ranges per site. So the cortical sites generally take less time. Again, so low risk cortical are going to be the fastest. And the fibula, with the low being the lowest weight bearing bone, essentially, is going to be one of the quickest. So that was averaging about 4 to 8 weeks. So then without having that B grade specific in my head, it's like, okay, if this is a lower grade injury, probably going to be closer to 4. If this is a stress fracture, then it's probably going to be closer to 8. If this person has low bone mineral density, it might be closer to 6 to 8, even if it's a low grade injury, because bone mineral density is actually an independent predictor of return to sport time as well. So we have all these factors at play here, but we do have ranges for each site. So again, fibula is about 4 to 8. Posterior medial tibia is like 6 to 12. Femoral shaft and metatarsal shafts are a little bit longer, about 8 to 12 weeks. Those are probably the most common low risk sites we see in athletes. I'm trying to think of any other lower risk. And then high risk sites, we'll probably get to that soon, but those are the main ones with low risk. Oh, I forgot the trabecular ones. So those are going to be a little bit longer. Sacrum, pubic ramus, and calcaneus are going to be closer to like 12 to 20 weeks. So you can see that difference from the trabecular source versus the cortical there.
For low risk sites, I asked if you could give kind of a case example of a specific athlete or kind of archetype of athlete and your own management of a low risk site. Can we dive into that?
Yeah, so I see a lot of femoral shaft and femoral neck bone stress injuries. I see mostly runners, so those will be more common in the distance running population. In more like jumping sport athletes, you're likely to see more, at least when we look at high risk sites, anterior tibial cortex, navicular, metatarsals, like more around the distal part of the limb in ball sport athletes. But since I treat mostly runners, we'll go with those. So femoral shaft BSI will be our low risk site that we'll talk about. I had an athlete come to me while training for the Chicago Marathon, and we have direct access in Arizona, so she hadn't seen an orthopedic doc. She was at the point where she was able to run and was still continuing her running, but was limping in the morning. She was hesitant to single leg squat, single leg hop. And I think this is an example of why these can be easily missed, because runners are notorious for just continuing through like, well, I can still run, right? I might be limping the next day, but I can still run. So this isn't that bad. But she was referred for imaging. She had a grade 4A femoral shaft bone stress injury. So grade 4 on the Fredrickson system is considered a stress fracture. Before that, it's considered a stress reaction. So she did have a fracture line, or cortical involvement is another way that we would classify it as a fracture versus just a reaction. So there's some kind of delineation there, which is important to know if you have to read the image, and it's not always clear when you get the MRI report what's exactly going on. So if they say there's cortical disruption, then it's a fracture. If there's no cortical involvement or disruption, then it's a stress reaction. And usually it'll also accompany bone marrow edema for the stress reaction side. So getting back to her case, we had her stop running. She was just limiting her walking, doing light body weight strength, trying to be as pain-free as possible. Did not go completely non-weight bearing because this is a low risk site. And I didn't mention earlier, but the reason that we have low versus high typically is because it's on the compressive versus the tensile side of a bone. So if you think about like, if I were to like break a stick this way, right? The top of the stick, if I'm breaking it, you can't see me on the podcast, but I'm bending a stick. So the top part of the stick is the tension side, and that's going to crack. The bottom side, if there's a crack on the bottom, is going to push together. So that's what we mean by tensile versus compressive side. So a bone stress injury on a tension aspect of a bone is more likely to completely fracture, making it the high risk site. And so this one, femoral shaft, they tend to be on the medial side of the bone, which is the compressive side. And so for her, even though it was a fracture, she never had to go non-weight bearing. It was just stop running. You can continue with your activities of daily life, but running, jumping, heavy lifting, limit your steps. And so that's a big difference between high and low risk sites as well, is that initial management. We'll talk about femoral neck later and how that's different early on. But for her, she was still having pain walking, but because this wasn't high risk to fracture, it was okay for her to keep doing her ADLs. And the benefit of not using crutches was higher than putting her on crutches and going completely non-weight bearing for this site. So with that said, we had her just gradually pick up her steps per day, essentially, after those first 3 weeks. She started doing double leg strength work, started biking. She was allowed to swim or aqua jog as long as it didn't create more pain. And then at the 6-week mark, she started doing some loaded double leg strength, progressed to body weight single leg strength, and started some walking outside, some hiking. And then at the 9-week mark, started some plyometrics and started her return to run around 10 and a half, 11 weeks. So for her, it was kind of like take a step back. and the average for a femoral shaft is 8 to 12 weeks. She had a higher grade injury, so pushed her more towards the 10 to 12 week mark. She got a DEXA scan, had normal bone mineral density, so it wasn't going to be pushed out further than that. And then along the way, of course, you're checking in. You know, she has to be pain-free with ADLs before she increases her steps. She has to be pain-free with double leg squats before she moves to single leg squats. Pain-free with single leg before she moves to plyometrics. So those are kind of the stages or phases that we moved through. There's not a typical protocol. You know, there's not any consistent return to run KPIs or key performance indicators for this type of injury. But I think based on the demands of running or based on the demands of someone's sport, you can start to kind of create your own, or maybe those will be created soon, and have them similar to even like a post-op protocol. Like, hey, before we start running, we want this limb to be greater than 80% of your peak force production, and quads, hamstrings as the other side. And with that said, too, something I forgot to mention early on, I'll have them start plyometrics and continue heavy strength training on their unaffected side so that they can potentially maintain some bone mineral density on that side, maintain strength, potentially some crossover effects to mitigate the strength loss on the affected side.
If you said she received a DEXA and she had normal bone density, if this was a situation where she was in a position where she had osteopenia or lower bone density to where something would be changed, what would have been changed? If it was the same individual, but you had those findings, what would have shifted clinically for you?
I would have added about a week to each phase. So I typically split up rehab into about 4 phases and then kind of do 3 to 4 weeks, sometimes 3 to 5 weeks in each. So I would imagine her pain would have guided it a little bit as well. You know, there's definitely like, okay, by the end of this phase, we want you to be pain-free with double leg squats. So if she's not, add a couple weeks. And knowing that the lack of, I guess, I don't want to say of optimal bone health, it's probably a good way to put it, is going to slow her healing. That would add about a week to each of the time frames in my head initially. And then it would still be based on her clinical symptoms and clinical presentation.
And throughout this process, you mentioned each subsequent phase to get there, they need to be pain-free in their current phase. If they transition and they're pain-free, but then sometime during that phase or during an exercise, they have symptoms that are similar to what they presented with early on in these low-risk sites, or for this individual in particular, how would you have managed that flare-up or those symptoms?
Yeah, that's not uncommon, especially when you start the return to run process. And I think there's a couple of ways to look at it. There's some information on like phantom pain where it feels like something's there, but it's not, you're not able to reproduce it. So that's what I'll have them do first is let's test single leg squat, single leg hop, the things that cause this to, that recreated pain early on is that still recreating pain? And most of the time it's not. So if there's a higher level of concern, this is an athlete who maybe does have low bone mineral density and we want to be a little more conservative with, then we'll have them take a few days completely off and then restart at the level below where they started having discomfort. And even if it is reproduced with single leg squat or single leg hop, then we'll add a couple days. So the big point is to reassure the athlete it's not refractured. we haven't done enough, for anything crazy unless they decided to go out and run on their own. That might have re-injured it. But I think the biggest thing is to reassure the athlete it hasn't refractured. Your bones are constantly adapting and remodeling. So we might have pushed it over the edge. There might be a little bit more bony edema there as it's healing. So let's take a step back and then we'll get back into the program after a few days. I don't know if this is documented anywhere, but I've learned a ton from Rich Willie, and he was the one who recommended 2 to 3 days off if it's a low risk site, 3 to 5 days off if it's a high risk site. So that's going to vary a little bit depending on the location of the injury as well.
And for the return to run process and initiating that return to run, does that look different for you based on the competitiveness or the just age of training for that athlete or that runner? Or are you starting, let's say, the first week or two with this initiation of running at a similar volume level and prescription level?
Yeah, typically I will utilize the athlete's history as well as take their bone mineral density and any current or history of restrictive eating into account. And I'm going to be more conservative with those athletes who maybe this has taken longer to heal. This is a higher risk site. This is someone who is at higher risk for another one. I will monitor theirs and be a little more conservative early on. For an athlete who's otherwise very healthy, it'll look pretty similar the first few weeks. And then the rate that we ramp up will be different based on their history and their goals. So some athletes too are, this is where a coach can be really helpful. Some athletes, come back from an injury and they have a marathon goal on the calendar. And so it's a big working backwards process of, okay, I know you want to do this race. How do we get you there without overdoing it beforehand and have you the most prepared that you can be without overdoing it? I think my recommendation, especially after a high risk site, is to not do an intense, like longer race, like a marathon or 50K for a year, because bone mineral density can change throughout bone stress injury recovery. So it's a hard thing to tell someone like, hey, you may not race really fast and really long for a year after this, but this is the long game. But to come back to your question, yes, it'll look different depending on the individual athlete, but those first few weeks generally look similar for, I'd say, like a certain type of athlete that's lower risk for this to occur again versus an athlete who's higher risk for it to occur again or be a high risk site.
Before we move on, could you be just a little bit more granular on if it's this lower risk, what actually would that first session or that first week look like of how much you'd be prescribing versus the other higher risk or more conservative population?
Yeah. So for someone who, we'll talk about her later, but an example would be the femoral neck, the gal with the femoral neck bone stress injury we'll talk about soon. So I'll just jump into it now. She had low bone mineral density. It was negative 2.4 at the lumbar spine, which is do you know how to grade, or how DEXA scans are graded? Should I go into that?
You can. Yeah, I
Okay.
don't personally know. Yeah.
Okay. So 0 is like the norm, basically. And then they grade it standard deviations away from the norm for your demographic. And T-scores are used in people over age 50 for the most part. Under age 50, we use Z-scores. It's just comparing to a little bit of a different demographic. So Z-scores are what we look at in, again, a lot of the athletes I work with. I have some above 50, but Z-scores is what we'll talk about today. So it's a standard deviation away from the mean. So 0 is the mean. So if you're at -2, that means you're 2 full standard deviations below the average for your demographic. And historically, it's been, quote, normal for people to be between -2 and +2. But the International Olympic Committee, the American College of Sports Medicine have both recognized, like, hey, athletes should have higher bone mineral density than the general population. They're putting their bones through a lot. So they recommend -1 and higher is what should be the standard. And then there's another movement essentially for high impact athletes to be above 0. So for an athlete with -2 or below, that's really concerning, especially, at a young age. We can definitely gain bone density after age 25. That's, I think, a myth that we've been told as well. Like, oh, sorry, you're 25, give up. But you can improve your bone density after age 25. But all to say, for her, for an athlete who is high risk, because she had a high risk site, we started off with 30 seconds of jogging, 2 minutes of walking, and did that 5 times. And she had been walking 15 to 20 minutes brisk before this, but it was a 30-second jog to start, very low level, versus this athlete with the femoral shaft BSI. We started off with 1 minute jog, 2 minute walk times 5. So double the running, it doesn't look like much difference initially, but the progression is going to be much faster for the athlete who has healthy bones, has a low risk site, versus the one that has some work to do on her bones and is a high risk site. But those starting points, because there's, kind of a floor effect, those starting points don't look a ton different, but over the following 3 to 4 weeks, you'll see a big difference. So the low risk site is going to get back to her typical training in probably 6 to 8 weeks, whereas more like 8 to 12 weeks for the athlete who has a higher risk for this happening again.
Is there anything else you wanted to touch on with low risk sites or that case in particular before we fully transition to high risk?
I don't think so.
Okay, let's do it. Let's transition. So we'll start again with, and you've already mentioned it, but let's go again to what are some of the high risk sites and why are they considered high risk?
So high risk are more likely to progress to a complete fracture, and they have a higher rate of complication, more likely to need surgical intervention, and have longer healing timelines. And part of that is because most of these are on the tensile side of the bone. So kind of like the example we talked about earlier, with the kind of natural bending of the bone, or what the ground reaction forces cause when we walk, run. These are on a side of the bone that's going to be more likely to break than the opposite side of the bone. So that, and then they tend to have a more limited blood supply. That's what makes them higher risk sites.
And then the return to sport timelines, you'd already mentioned the higher risk, there's going to be inherently longer timelines. What other things besides timelines are you educating with patients on these higher risk sites versus the lower risk that you may not be emphasizing as much, or that are just totally different?
Yeah, so the initial management varies quite a bit. And so the education on needing to stay off of it. So this is where, with a navicular, anterior tibial cortex, or femoral neck, these are probably the 3 most common high risks that are studied and that I've seen. It is so important to go non-weight bearing. Even if someone came into me and they were limping in, I would send them out with crutches, because we need to get them off that bone as quickly as possible, versus a lower risk site, they can walk themselves into the imaging center. So the importance of getting off of it, of limiting your steps at home as much as possible. And then I think the psychological aspect too. These are injuries that they're going to lose their fitness. This is not hey, I'm going to keep swimming or cross training through this to make sure that I can get to my race in 3 to 4 months. These especially are huge changes to someone's identity, to their social life, to their ability to kind of regulate emotions. A lot of us use activity as a stress relief as well. And so I think one of the, again, for all bone stress injuries, but especially these that can be up to 6 months before you're even starting your return to run or your return to sport, that big piece of being there as a support person, as a guide throughout this process. And without scaring them, letting them know the possible consequences of not offloading it soon enough.
How long are you recommending they stay on crutches for?
So typically they need to be non-weight bearing until they're pain-free with the activities of daily life. So typically for like a navicular bone stress injury, they'll be in a boot and on crutches for 4 to 6 weeks. For a femoral neck stress fracture, so a higher grade one, 4 to 6 weeks as well, and then gradually start to do toe touch weight bearing, move to partial weight bearing to full weight bearing. So it's really person dependent, but the criteria is that they have to be pain free with putting weight on it before they're back to full weight bearing.
And these education pieces, and this could go for both low and high risk, but outside of the timelines, outside of the weight bearing or not weight bearing, these pain free markers and progressions, what are you discussing, or also referring from a nutritional standpoint and potentially, sports psychologist? How do you get into those realms with the patients and or their parents, and how do you recommend clinicians kind of navigate some of those trickier topics and subjects?
Yeah, I think probably the easiest way to initiate the conversation is to put things on your questionnaire that relate to relationship with food. If they've had any thoughts about restricting food, any periods of restrictive eating, any periods of trying to lose weight, any thoughts about body size, body image, so that you kind of have an entry point. There's the FAST questionnaire, female athlete screening test, is one that can differentiate between eating disorder and subclinical disordered eating. So it's a long questionnaire. That's not our scope to diagnose someone with these conditions, but it can give you an entry point and without accusing someone of having an issue, start to lay the foundations of like, hey, here's what you have, here's how long it takes. Here are things that we have control over that can help improve your bone's ability to recover. We have so much evidence that underfueling contributes to increased risk for BSI, whether it's subclinical disordered eating, unintentional RED-S, or a actual clinical eating disorder. So much research points to that as impacting bone health. So, hey, let's just make sure. Are you interested in talking to an RD? This can help you recover faster. This can help you perform better once you get back to racing. And then it's kind of the registered dietitian's role to recognize if they have any other issues with eating. Within that, then, referring to a sports psych if they are having a lot of issues with the transition into being, quote, an injured athlete. I think that's always we know the mental side of recovery can be so hard, and that I actually don't know the research on this, but I would imagine that having a positive outlook on recovery helps you recover as well. And so just kind of laying those, okay, here's, right on a whiteboard, or whatever, the list of like, here are things that we can control. Our limiting factor right now, or our rate limiter, is your bone's ability to heal. There's some genetic component to that, of course, but like, what else can we do to facilitate that and get you back as soon as possible and reduce the risk of this happening again? So I think opening the door to that conversation, it's our responsibility to ask these questions, recognize and refer out, and not feel like we have to address that component, but refer appropriately.
Have there been situations where you recognize that there needs to be a referral and you're making these suggestions and recommendations, but they're not following through, and you're kind of in this standstill of, these components probably need to be implemented from a physiology and psychology standpoint to progress from a rehab perspective, but I can't because they're not interested or willing or ready to pursue those options? Have you had that happen? And do you have recommendations on how clinicians can kind of navigate that as well?
Yeah, absolutely. And that's a really complex conversation and issue. There is, I think, a readiness for change. There's so much that goes into wellness and food culture. So I have had that happen. And I think continuing to just educate, like, hey, this resource is here for you. I think if that piece isn't there, then we're going to be more conservative with your progression. That's not a threat or, anything like that. It's just knowing that there may still be some restrictive habits going on that we probably aren't able to progress as aggressively, because we want to make sure that you're not getting into an energy deficit at any point when you're building your activity goals again. So that's how I'll put it. I think I've been there too. I didn't mention this earlier, but the reason I got into this is I had an eating disorder and I've had multiple bone stress injuries. And, I think just having the support, having the resources available for when you're ready are the biggest piece, because the worst thing you'd want is to push someone into it and they're totally resentful, they're not buying in anyway. So just understanding like, hey, I get that you're not ready, and here's what your program is going to look like. That's different because I'm taking into account your body's current capacity, your potential energy deficit. And I think with these injuries, you can be too conservative. Having someone be in a boot with a low risk site for 3 months is probably too conservative. But for once an athlete is back into weight bearing and back into their getting close to their return to training, I think we do want to be a little bit more conservative with that progression back to higher levels in this population. Because again, that recurrence rate is so high that maybe we're doing something wrong with how quickly we're getting people back.
Is there anything else for these higher risk sites from a mistake standpoint that you want to discuss or that you see commonly or clinicians just aren't realizing they're doing? Obviously, a big one is they don't realize that they should put this individual on crutches immediately or have those education points. But are there any other mistakes that you've commonly seen with mismanaging these higher risk locations?
Yeah, I think this probably applies to lower risk as well, but is more serious and higher risk is the misdiagnosis as like a hip flexor strain for a femoral neck BSI, or um, there's all kinds of diagnoses in quotes, of malaligned pelvis causing your hip pain or your tight hip flexors. I think these can have serious consequences if we're missing them in the high risk sites, especially. So just as a clinician, making sure that with hip pain, with adductor pain in an endurance athlete or a high impact athlete, that you're going through your list of differential diagnoses and proving to yourself it's not a bone stress injury before moving on with your treatment. And you still want to use your clinical reasoning, of course. If they're only having pain with sitting and it's not worse after they run, but it's in their hip, it's probably not a bone stress injury, right? Definitely still use those kind of special test-ish. maybe not a special test, but use your testing, use your clinical reasoning, but keep this on your radar to make sure that you're not continuing to have someone stay active on something that might be more sinister.
You touched on this individual that we're going to use as a case study a little bit already to talk about that return to run process, but let's go fully into that individual's kind of plan of care and how this high risk site treatment looks different than the low risk.
Yeah, so as I mentioned, she also came in to see me without having imaging first and was limping in. I sent her off on crutches. She had a grade 4A stress fracture of her femoral neck as well. And so she was on crutches, fully non-weight bearing for 4 weeks, and then started some toe touch weight bearing, progressed to full weight bearing over the following 4 weeks. So she was either non-weight bearing or essentially partial weight bearing for 6 weeks. During that time, she did have a DEXA scan as well. She was the one I mentioned who was about 2 standard deviations below, which in the T-score realm would be classified as osteoporosis in an older population. It's not necessarily how they diagnose it in the younger population, but just to kind of give people a reference point, it's pretty low. So I would imagine that and then in other cases, they might be off crutches within 3 to 4 weeks. It's not typical to take 6 weeks, but she was a little bit longer. And then from there, we gradually progressed her into double leg weight bearing again. It looked fairly similar, just a longer timeline to the femoral shaft case we talked about earlier. So going from double leg loading, progressing to single leg, being really careful more so though with her with resisted hip flexion, because that can be aggravating initially, thinking about the site of injury. So we also didn't have her start biking as early because that was painful, especially if she was clipped in with that resisted hip flexion motion. So that's another thing to think about with the site of injury is the muscles that attach to that bone are going to create some stimulus on the bone or some strain, which we need for those bone changes to happen. But early on in a compromised bone, that can be painful. So just keeping that in mind as you start your exercise programming, like let's not jump into resisted dead bugs in someone who had a femoral neck BSI. That's probably going to be painful. And luckily you get feedback pretty quick with a bone, and you can have them stop doing the painful activity. But as we work through this program, then we eventually want to re-stress that injured site. So for the femoral neck, moving her more into hip extended positions, doing some more resisted hip flexion, and abduction and adduction are pretty weak in this injury too. I'll see a lot of times as people come back, they have significant lateral hip strength deficits. So working on a lot of single leg stability when she was able to get there, progressing single leg loading and tolerance, plyometrics, and then return to run. And again, I forgot to mention in those first 3 weeks where she was non-weight bearing, having her do some upper body, some strength on the uninvolved limb, and then non-weight bearing pain-free strength on the involved limb. And I think that can be important depending on the case. I go back and forth on this now. I used to be really gung-ho about like, let's do everything, give them a plan in those first few weeks. And some people just need to rest. Like you're expending a lot more energy being on crutches. And in someone who's already in an energy deficient state, she was still struggling with restrictive eating at that point. Maybe just living life on crutches is enough to have them enough energy for them to expend at that time. So again, very person dependent on how much we want them doing during that period of non-weight bearing. But then gradually working that up. And she didn't start her return to run until about 18 weeks.
For the period of crutches that she's non-weight bearing, and then is there transitioning to she's still using the crutches, but it's toe touch weight bearing or weight bearing is tolerated, and then a discharge from the crutches? How does that transition look?
Yeah, so after about 3 to 4 weeks, people will already start to test it, I think, on their own a little bit. But started doing some like heel toe, just practicing putting her foot down while putting full weight on the crutches. And then over a period of a few days, starting to put more weight on that foot. And then over the following week, I'd have her stop using the crutches and just walk normally for 2 to 3 hours. We didn't track the steps, but I would do that now. And then use the crutches for the rest of the day. So no prolonged walks, just ambulating around the house in between calls or, at work. Luckily, she worked from home, so that was easier. And then each subsequent day, basically increasing the time that she wasn't using the crutches by a couple hours until she was off the crutches all day. It can be really helpful, though, to give them a step count to hit as they gradually work back into, especially if there's someone who has a dog or is like, oh, I can walk now. Let me just go off, do 10,000 steps. So giving them guidelines can be really helpful. I don't have anything standardized for that, but I think a logical progression of steps per day makes sense.
And then she started that return to run, as you said, 30 seconds of running, 2 minutes of walking for 5 rounds. Mm-hmm. And then the rate of the progression is just generally going to be slower than these low risk sites. What does slower mean and look like for her? How was that slowed progression compared to that other example of the low risk? How fast is that rate in low risk versus high?
Yeah, so for her, we did each level twice at first. So I was like, let's see how you respond. Take 2 days off, try it again, take 2 days off. And so she started at 18 weeks. She wasn't back to her typical training, which was a lower amount than the other athlete we talked about. So her typical training was 15 to 20 miles a week. And it still took her 10 weeks to get back to that. And it's a, gradual ramp up by no more than 30% a week in minutes. That's what I do. Again, I don't think that's based on science, but things I've learned from mentors, approximately 25 to 30% increase each week. And then I'll do a deload, even at these low levels of running every 4th week, because of there's a period of time where, we have bony breakdown and the bone density is actually lower before we have the osteoblasts come back in and build up. There's no way for me to know when that's happening, but to potentially help with the bone acclimation process every 4th week, I'll deload by about 30 to 40%, again, from the minutes that they ran the week before. So for her, it took 10 weeks to get back to 15 to 20 miles per week versus the femoral shaft or the lower risk site example. She started at 10 and a half, 11 weeks. We're in the middle of it, but she'll get back to normal training probably around 17 to 18 weeks, and that's closer to 30 miles per week. And so hers, we're bumping it up by a few minutes each time rather than doing each level twice. Still with that same rule of not bumping it up by more than 30% each week and doing that deload week on the 4th week as well.
And do you have general recommendations on prior to the walk jog? Are you doing any type of like plyometric prep or jump training? And what does that initiation look like?
Definitely. Yeah. So let's see, probably depending on the case, 2 to 4 weeks before their return to run starts. We'll start some double leg plyometrics, make sure they tolerate it, just pogo jumps. Depending on the person, sometimes they'll use a metronome, sometimes they won't. Um, it's mostly depending on their access to it and their rhythm. If it's going to be frustrating for them, we don't need to do it. But start with double leg hops and add in some like multi-directional hops, depending on the site of bone. We want to stress that site, right? So from the, like if it's a metatarsal, we'll want to do more ankle biased jumping. At the femoral neck, actually what seems to be most osteogenic for it is single leg hops in multiple directions because you get some of the bending of the bone. So very dependent on the person, but I'll start off with frequent but low dose. So starting off with 3 times a week and then going to daily hops, just a short dose, 5 to 10 jumps in the morning, at lunch, and at dinner. And because bone responds well to that higher frequency, lower volume. And so depending on the site, we'll be doing a different type of jump, but we'll progress from double leg to single leg over the span of a week or two, again, depending on the case, and then have them continue with their plyometrics pretty much throughout the course of rehab. When they start their return to run, I'll pull back on those plyos on the days that they run, just from the perspective of like, they're maybe getting some of that plyometric impact from their run. Again, it's an inexact science, but that's my way of doing things. Keep them with their plyometrics on non-running days, but have them pull back on their running days. And then we'll reintroduce it again after a couple of weeks, but keeping this higher frequency, lower volume jumping really as forever at this point. Like they should be doing some level of plyometrics, especially if they have low bone mineral density, with the idea that it could potentially help to improve it. And same thing with heavy lifting. So I like to get them to the point where they're doing some heavier back squats. That axial loading is what's been found in research to help with specifically lumbar spine bone mineral density. So that may be more important for this athlete who we know has low bone density, but I try to have everyone do it anyway, even if their bone density is normal.
Do you have a preference on the days that they're running? They're also strength training, so they have full days off in between, or it's kind of just whatever's realistic for their schedule, or you want to do it on non-running days? Do you have a preference?
I go back and forth on that quite a bit. Right now, a big part of it, as you mentioned, is what works for them. A lot of people schedule-wise can't get to the gym and run in the same day. So I think preferably, like in a perfect situation, someone would do a run in the morning, they would lift in the afternoon, and then have a full day off, still doing their intermittent plyos, and then do that again. But that's not necessarily the way that we can get things done. So however it works, but I always have people do their running first.
And for the low risk example you used, or the high risk, you're preparing for discharge, they're about to be discharged, and they ask you, how do I reduce this from happening again? Or what can I do to prevent these from occurring in the future? What are these kind of like send off messages or big education points you have for your athletes?
Yeah, so we come back to the foundations first, especially in those trabecular sites. Making sure, doing your best to make sure that you're eating enough. And there's actually some research now that low carb availability can impact bone formation and bone breakdown as well. So no keto diets, eat enough. Be in communication with a registered dietitian, especially in high periods of training. Get enough sleep, manage your stress, the things we tell most people when managing injury or pain. And then a smart training progression. I think having a coach can be really helpful, a knowledgeable coach, having deload weeks or advocating for deload weeks in there. And then just being cautious with intensity. Bone responds more, significantly or aggressively to intensity than duration. So you could theoretically do lots of slow, easy miles and be less at risk for bone stress injury than someone who's doing a fewer amount of miles at a really intense pace. So just be really cognizant of your increases in intensity. And then for certain, like especially the cortical sites, there may be a biomechanical aspect. So that's kind of like top of the pyramid. We work through the other pieces, stay on top of your strength work. I don't think we have any conclusive evidence that strength training reduces the risk of bone stress injury, but maybe that'll come at some point. I think there's a lot of other benefits to strength training. So helping people stay on top of that. And then knowing, that bone that was injured likely does need continued strength work if we want to stimulate more bone changes there and strength gains in that bone. So that can be a good sell for strength training as well. Because once you have a stress fracture for multiple reasons, many of which we don't know yet, you're at higher risk for another. So maybe strength loss, maybe a compensation might contribute to that. And then if it seems helpful, then we'll look at their gait as well and might make some recommendations in that way. But oftentimes, again, those are temporary and can be helpful more in that return to run process. Like if someone has a big crossover pattern, maybe that's contributing to some of the compression on the medial side of the femoral shaft. So let's increase your cadence as you get back into running, and maybe that'll more gradually increase the load back on that bone rather than like totally changing your gait. How do we manipulate your gait now to manage the amount of stress that's going back into that site that was injured?
Steph, is there anything else before we wrap up that you feel like we didn't touch on that you want to discuss?
No, I feel like I talked a lot. I'm just really passionate about this, as you could probably tell. So I really appreciate you having me on and the questions. And I hope it was helpful for people.
Yeah, I think it was. And it's obviously these case studies and these examples helps just with the practicality of clinicians needing to know some more tangible information outside of some of the general scientific and physiological understandings of BSIs. Like, how do we actually implement some of this? And I think it was super helpful. I wanted to provide one more resource, and I don't know if you've looked into this, but Nathan Carlson, a previous guest, he just came out with a variety of bone stress injury protocols. As you alluded to, there's not a ton of great literature on true protocols that are published, but Nathan, and I haven't looked through them, but I trust Nathan that he does, I think, these different little booklets of management of bone stress injuries in the femur, in the sacrum, in the tibial, different regions, that if people feel like they're still needing more information and they have an athlete that has a specific BSI, I would highly recommend going to his website, and I can link it as well for people that kind of need a little bit more guidance also.
Yeah, he has stress fracture school, I think, coming up again too. So a course
True.
To dive a little deeper, but he's a great resource. I've done stress fracture school. It was awesome. So very
Any
much
other
support
resources that you feel like would be beneficial for clinicians to know?
Yeah, Rich Willie has a course as well, Montana Running Lab, and I think he has a fall sale. So go get that. Rebecca McConville is a dietitian who is the go-to resource on relative energy deficiency in sport. She's a good one to follow as well. I think Greg Lehman has some great stuff too, just in general on his running resiliency course is awesome. Not specific to bone stress injuries, but he does have a bone stress injury section. So I've learned a lot. I've learned a ton from them. And then, I've also done a lot of digging on my own. So feel, encouraged, find resources, go to Google Scholar, PubMed, type stuff in, just get curious. And it can be overwhelming, but I think reaching out, I've had Nathan and Rich as mentors. And so reaching out to people who you want to learn more from can be really helpful too.
Awesome. We'll call it there. Thank you so much, Steph.